Sunil, I think it's Kolkata, supported by the Department of Labour, Government of West Bengal. I also express my heartiest gratitude to Chairperson and all the esteemed faculties from all over India. Welcome to Dr. Professor G.P. Dureja, Professor Dr. Ashok Saxena, Professor Dr. Bobita Ghai, Dr. Chandrasekhar Cham, Dr. P. Vijay Anand, Dr. Anurag Agarwal, Prakash Kasliwal, and Dr. Devendra Singh. Estimated worldwide lifetime prevalence of low back pain varies from 50% to 84%. Low back pain accounts for 19% of all workers' compensation claims in US. So, I think this webinar will help us to understand better about the diagnosis and management of different types of low back pain. I wish a grand success of this webinar. I request Professor Dr. Dureja, the pioneer of pain management in India, to start the proceedings of this session, and wishing you best wishes for good health and stay safe. Please stay safe in this present situation. Thank you all.
Thank you, Dr. Aditi, for that lovely speech and introduction to all the faculty members. And whenever, I've come there twice, and I really immense respect and immense pleasure whenever I come to the ESI Institute of Pain Medicine, because I think that's the only authentic institute in the country which is providing an excellent services as well as academic care for the people who are studying there. So I have a lot of respect for your institution.
Thank you, sir.
Thank you so much.
All are with your support.
I must tell, Dr. Aditi, last when I was there to conduct an examination, I was so involved with the students that I almost missed my flight because, I was trying to teach them and also get answers from them. And I was almost missing my flight when I last came there. And I hope to come there again whenever you invite.
Thank you, sir.
Thank you so much. So, Subrata,
yes, sir.
You have organized a lovely webinar, the subject being back pain. And we all know that almost 50-60% of patients who come to pain clinics or even to an orthopedic surgeon or to a general practitioner also do come with back pain. Unfortunately, I think I will request Subrata, we must have some prevalence data in our country that what is the prevalence of back pain. We don't have any prevalence data. Neither the orthopedic surgeons have prevalence data, neither we as pain clinicians have. So we must do some prevalence study so that we exactly know what is the prevalence of chronic back pain or acute back pain in our country, because we come across every day. And in fact, I was joking with my consultant the other day, because we are of course working right from 22nd March. We did not have any off day, pain being an emergency. So I was just joking now because everybody is under lockdown. So we will not have back pain patients because they are not moving out. They're not doing any physical activity. But to our surprise, this you must note, to our surprise, we are getting a lot of back pain. And reason, why? Because, of course, there are no maids, so females have to work hard. They have to do all the household activities. They're bending forward, lifting weight, and getting back pain. But men too, surprisingly, the men who have never worked in the kitchens are now working in the kitchen, doing all household activities. And I was just video conferencing a guy who had severe back pain. I said, what happened? You are under lockdown. What were you doing? कहता सर पूछो मत, अब मैं झाड़ू लगा रहा था and there was some sound in my back. So these are different challenges. These are lockdown challenges. Imagine, I'm almost seeing 1 or 2 ladies and men suffering from back pain because of the lockdown, which I never anticipated. I thought कि back pain तो खत्म हो जाएगा. So this was quite surprising. So let's start with this, and I think you have made a beautiful program. 3 very important topics like discogenic pain, vertebral compression fractures. In fact, 4 days down the lockdown, I did a kyphoplasty because patient was in severe pain. And of course, the failed back, which is really a nightmare for us. We are covering these 3 important topics. So we have a moderator for each session. I would like to call upon Dr. Gargi Nandi, she is the moderator for the first module. And Dr. Gargi Nandi is the academic coordinator at the ESI Institute of Pain Medicine. And she will conduct the proceedings of the first module. Dr. Gargi Nandi, you can take over, please.
Thank you, sir.
A very good morning to all of you. Hope you all are safe and doing well. I would like to give my heartfelt thanks to the chairperson, Dr. Vidya sir, all esteemed panelists, and all the delegates for your gracious presence in this hard time of pandemic on behalf of ESI Institute of Pain Management. With the permission from the chairperson, I would like to start the first case discussion on discogenic pain. Our esteemed panelists are Professor Dr. Ashok Saxena, Dr. Subrata Goswami, uh, Dr. Chandrasekhar Cham, and Dr. Devendra Singh.
So if you give me permission, I'll just introduce them.
Yes,
of course,
sir.
Professor Ashok Saxena, all of us know, he is a professor and head of the department at the UCMS and GTB Hospital in Shahadra. And we all know that he is perhaps the pioneer in pain medicine in our country. And not only clinical, but I think the type of work, the basic research work which he is carrying out is exemplary. And recently he has been awarded the Best Researcher Award by the International Association of Study of Pain. Unfortunately, we would have seen him in Amsterdam this year, but no problem. We'll see him next year when he is accepting this award. Dr. Ashok Saxena.
Thank you.
Of course, Subrata, yes, Subrata, everybody knows he's the coordinator and a faculty at the ESI Institute of Pain Medicine, coordinator of this webinar, and he has been a very, very enthusiastic pain physician who has been really working very hard and taking part in lots of academic activities. And in fact, I would say he's one of the most prominent, he's rather one of the prominent pain physicians in the country, as well as in West Bengal. Chandrasekhar Cham is a pain physician who is working in the Orange City, Nagpur, and he is an independent pain physician, and he was also the vice president of the Society of Study of Pain of India, and he is doing a lot of work in pain medicine in the city of Nagpur. And we have who is the fourth one? Sorry, we have Devendra Singh. Devendra Singh is a very young but very enthusiastic pain physician who is working in Sahara Hospital. I had a chance to meet him 3-4 years ago when I went there for a lecture, and he is a very promising pain physician who is taking part in a lot of academic activities as well as in research activities. Over to you, Nandi.
Thank you, sir. The case which I am going to present here is a real one. I have just changed the personal details of for the identity issues. Mr. Raja Roy, a 25-year-old male patient, a truck driver by occupation, attended our pain OPD on 16th May 2019 with the complaint of gradual onset of low back pain since 5 years without any radiation to leg. The pain is vague, aching type with mild burning sensation. Pain usually aggravates during the prolonged sitting and standing, but relieves in supine posture. There is no disturbance of sleep and bladder bowel habit and no diurnal variation. He attended ESI Pain Clinic almost 1 year back for
Pardon, just interrupting. I cannot see the screen. Have you shared the screen?
Yes.
We cannot see the screen. We cannot see your PPT.
He attended ESI Pain Clinic almost 1 year back for first time. After that, he is on anti-neuropathic medication such as gabapentin and amitriptyline. Due to pain aggravation, he received 1 dose of caudal epidural steroid injection 5 months back, but the pain relief lasted for only 1 month. As he is only a member of the family, he is very much anxious about his back pain. Now his NRS score is 6. On examination, we found nothing significant except mild midline tenderness from T12 to L5. This is a picture of the caudal epidural which was given, and these are the reports of routine blood test and EMG NCB of both lower limbs which appear to be normal. So the provisional diagnosis is the patient is suffering from discogenic low back pain. Now I would like to ask Dr. Subrata Goswami sir that what is the cause of this type of pain? Means what is the pathophysiologic changes behind this type of pain?
As it has been diagnosed as a discogenic pain based on the clinical and also based on the failure of the treatment, also of the interventions, not that much. And also we have seen the radio imaging also. And so probably the pain is coming from the disc, that the disc itself is painful. And because of the degenerations, we know that the nucleopulposa cells get nutrition from the blood vessels around, and with aging or with atherosclerosis or anything, when the vessels are unable to provide the nutrition and the fluid to the disc part, so that part gets dehydrated, degenerated, it shrinks, and it tends to come out. There are lots of fissures. And in an attempt to repair those fissures, there is granulation tissue which grows from outer side to inside. So along with the blood vessels and granulation tissue, lots of nerves also go in. So when the patient is putting load, that is on standing or walking, then that granulation tissue, there is pressure on it, and it is mechanically or chemically that gets sensitive, and the pain starts coming. So that is the pathophysiology of the discogenic pain, this degenerative pain, and followed by granulation tissue and the growth of the nerves from outside inwards.
Thank you, sir. Now, good morning, Dr. Cham. My next question to you, sir. What investigations will you suggest for this patient?
Dr. Cham is here.
Dr. Cham?
Dr. Cham joined. So,
hello.
Yes.
Yes, it is
Morning,
audible.
sir.
Yes.
Good morning,
Yeah.
Dr. Cham.
Morning.
Yes.
See, the discogenic pain represents one of the most difficult to diagnose for a physician, because there is no such specific thing about the discogenic thing. On that basis, we can diagnose. Most of the time, it is the exclusion criteria of history, physical examination, and investigation by which we can diagnose the discogenic pain, as you said in your slide also. The two things which is very important in the history is to first is to evaluate the identification of red flags, and second to just localize identification of other cause of low back pain. You can just have exclusion on that basis, so that we can reach up to the diagnosis in the history, and in the physical examination you get a pain in the spinous area in the midline, and biphasic straining from flexion is considered by some to be an indication to discogenic pain. If you consider the investigation, then the blood, I don't think we'll get anything from the blood. Main investigation is the radiology, X-ray, MRI, and CT, and that also will not give a detail about the any diagnostic point for the discogenic pain. High intensity zone has been correlated with the presence of discogenic pain, but it has been observed that it can also be found in asymptomatic control patient. And the most diagnostic in case of discogenic is the discography, and provocative discography is the only gold standard test currently available in the diagnosis of discogenic pain. So is it okay for the investigation part?
Yes, sir. And I have another one question to you, sir. Practically, is it feasible to do discography for the sake of diagnosing discogenic pain only for the sake of?
I I disagree with that. I don't do much discography because validity of discography has been challenged on the ground that the disc stimulation can be painful in a asymptomatic patient, and there are false positive, uh, and there is no guarantee intervention or surgical outcome of that. And positive response does not rule out presence of other source of pain also, nor prove the clinical significance of the pain or whether disc is primary pain source. So I am not in a fear doing discography in all the patient to diagnose the discogenic pain.
Okay. Thank you, sir. Now see what we have done to this patient. We do a X-ray of LS spine where we found only marginal osteophytes. I failed to collect the picture of X-ray from the patient due to. Next, we did a MRI of LS spine. Here we can see the degenerated L4, L5 and L5S1 disc. Also fibration on the disc. But there was a discrepancy between the MRI findings and the patient symptom. That's why we perform discography, where we see the L5 disc is mechanically sensitive and L5S1 disc is chemically sensitive. We also perform post-discography CT scan. Here is the plate. We can easily delineate that L4, L5 disc has great clear of annulus and L5S1 disc has poor annular clear, but the disc is content stage of dye in epidural space. A very good morning to Professor Saxena.
Oh, good morning. Good morning. Very, very good morning.
Always nice to hear from you, sir.
Thank you.
My question to you, sir, what medications will you suggest in this patient, especially for the neuropathic component of pain? Because there is a mild burning sensation also in the low
Right. Well, neuropathic component, in such a condition can always, first of all, I would just like to add one sentence here, that it has been seen very recently that MRI pictures in discogenic pain have shown hypermobility. That's a very important factor. And that hypermobility is an important factor which induces discogenic pain. They have seen, and what Dr. Cham was saying was absolutely correct, that on that basis they have defined Modi's type 1, type 2, type 3, where type 1 is low intensity on T1 and high intensity on T2. Modi's type 2 is high intensity on both T1 and T2, and Modi's type 3 picture in MRI has been noted as low intensity on both T1 and T2 weighted images. Just in addition to I absolutely agree with Dr. Cham what he was saying. Now, regarding the medication, all of us are very familiar with the guidelines which are there, the NUPSIS guidelines of ISP, and also the one which we brought out in the Indian guidelines, and very, very clear cut, in the sense that you can start with your either gabapentin or pregabalin. Choice is entirely yours. This, if you want to start with gabapentin, you start with 300 milligram, and obviously, you're going initially on a low dose and then making it TDS, and then gradually you can titrate it. You can make it as 2 TDS also over a period of time. But then the thing is here that we should also start when we started gabapentin, and obviously you need to give enough time, though we know that it has a linear pharmacokinetics, is that we need to add amitriptyline also well in time. And that again, 10 mg or 25 mg, I've never very rarely used 75 mg per day, but then 25 and 50 is very common in such kind of. But the point is, when patient is not responding to any one of these, we also have the option of using a combination of gabapentin with nortriptyline or pregabalin with nortriptyline, with variation and choice according to the treating pain physician. You have those available in the market, that is 75 mg pregabalin with 10 mg nortriptyline, or the other way around with gabapentin also. And then accordingly, you can titrate this combination, gabapentin plus nortriptyline. Or people have also used gabapentin plus duloxetine also, taking duloxetine as 20 mg BID. that's a reasonable one for Indian patient, or at the most 30 mg BID, but not the dose of 120 mg per day, which is actually very high and suits mostly the Caucasian race, but not for Indian one. So I think we can always have this particular choice of gabapentin or pregabalin and using a combination with nortriptyline, and so that's a good one, along with the help of your topical agents, using the topical creams and all those kind of things. So that's the first line of drug, and if you are not getting response to this particular neuropathic pain medication, then obviously it calls for those switching over to intervention. You can always follow the algorithm. You can take your time of 15 days, 4 weeks, 6 weeks, depending on the urgency and the emergency and the way you can take it. But the other thing which comes to which we have been using is that if the patient says no for intervention, and patient, sometimes of course can say no for even these medication also. You never know. Many of the patients are not willing, but then yes. And then if you ask me, you can have an integrated approach, combination of these neuropathic pain medication along with your cognitive behavioral therapy. That's in brief.
Yeah. To you about the CBT letter.
Right.
Sir, is there any evidence available in Indian scenario about this pharmacotherapy in the neuropathy?
Any evidence? If you're asking me about this neuropathic pain medication in discogenic pain and the publication, well, I have not been able to find. If I'm correct, maybe Dr. Goswami or Dr. Dureja can correct me. Probably they might be having, but somehow in discogenic pain, I could not find much of the evidence in the Indian literature as far as the neuropathic pain medication usage or the randomized or the RCTs are concerned for that. So that I say sorry for that. We have not been able to find that. Regarding the medication in discogenic pain, if you specifically ask me about neuropathic pain medication, yeah.
From this, we came to know that patient is very sick, as he is the only So, what do you this type of chronic low back pain sufferer?
Right. Sorry, there was break in the voice. I heard the last word only, chronic low back sufferers, and your initial part was?
The CBT can.
Okay, all right. Now here comes the that if I use a philosophical statement that human mind is very strong, in the sense that human mind can make hell out of heaven, and human mind can make heaven out of hell. So if I'm saying heaven out of hell, means somewhere I'm hinting at that yes, the person can be successful. But if I say that only CBT alone in discogenic pain, I'll be wrong in saying that, unless until patient says no for anything. Patient says no for medication, patient says no for intervention. Then yes, you have no other option. So if you ask me about CBT, well, in 50s, it was, this is where, your intellect, your intelligentsia, your intelligence and your intuition, when all these three move inward, that is where is the beginning for cognitive behavioral therapy, if I can use these right words for that CBT. Because CBT has its own indication. The patient where you can't get any cooperation at all, there is no point planning for CBT. That's very important. And before CBT, you must look for the yellow flags. It's very important, If I say A, B, C, D, E, F, and W, like A stands for attention and attitude. Anxiety means attention to pain. Always remember that. And in that anxiety level, when you find in patient of discogenic pain, you have increased activity of the somatosensory cortex, and you have increased activity of the anterior insular cortex, also insula. So you need to know about A is for attitude, B is for the behavior, but whether they have reduced their activity or not. C is for compensation, very important. Many of them are waiting for that particular claim which they have filed for, those kind of background things may be there. Then is there any conflicting diagnosis? But here we are sure, yes, it is discogenic pain. Then E is for the emotions, the emotional behavior of the patient, very important. And lastly, the F is for family. The family support, is it there or is it missing? So this A, B, C, D, E, F is very important. And last one is the work, that whether they are working still or they are off work. When they are off work means without any job, again, they are big sufferers, So this is where they brought out fear avoidance model, where this was designed. They say that if the patient is positive, and then yes, they can get over it, but there are those who have the increasingly negative orientation towards pain, and they have the fear of movement and all that. Then yes, there the catastrophic features start, and there you will have the hypervigilance phenomena operating over there. So coming to CBT, where CBT, you can, it is something which can help manage problems by changing the way the patient thinks and the way patient actually can behave, those kind of things. It is actually not designed to remove any of the underlying problems. Please remember that. It can help manage them things in a more positive manner. And all that they have to do, if I can just sum up, is that patients should be able to identify the distorted thinking. That's very important. They should be able to identify their catastrophic thinking. They should be able to identify. Then they have to change their outlook, right? And they have to produce some constructive action, and that comes with training over a period of time. And finally, they start feeling better over a period of time. So remember here, there was a survey done in US with chronic pain patients were asked, and then they said, what do you want, after all this therapy? They said, we want to enjoy life, So when patient says you want to enjoy life, you want to have party every night, that's not the thing. That's not what we are training them. We are actually training them to actually improve upon their pain, to make them more flexible, and to reduce their disability, and to make them more functional. So these are the aims of cognitive behavioral therapy. So this is where, our action is that we want them to feel better, and that's where, but you need patients' cooperation, and you can do it in groups, you can do it as individual, you can also do it with the help of self-study and self-help books, you can do it with computer and all those kind of things. And it can always be incorporated into daily lifestyle and all that. But yes, as I said, it should not be done in those patients where you don't get cooperation, and it is not a holistic approach as such. You have other methods like mindfulness-based stress reduction exercises. You have ACT, or what you call as acceptance and commitment therapy. Now, mindfulness and ACT are one part, but CBT as such is something which is it encompasses all these aspects, both cognitive and behavioral. And then there are evidences also, especially in low back pain. A lot of work has been done. So should I go ahead with some of the evidences which are available on CBT in this in hello? Should I? Okay. So, but what evidences I would be giving with the CBT in low back pain is not confined to discogenic pain. Let me tell you very clearly. That's the work which has been done in chronic low back pain. As such, they have not specified discogenic pain. But yes, there are positive outcome reports also, and there are negative outcomes in research. But there are more of positive outcome reports in research, where the one is by Smeets, long time back, around 10 years back, where they had taken more than 200 patients and they found good results. They had taken BDI, or back depression and inventory, and they had also taken the Roland Disability Questionnaire as one of the parameters in addition to pain VAS. So they found good results with CBT as such. The other one was with Camper, which appeared somewhere in, that's the latest one in 2014. After that also, the 2014 one is interesting because it is based on Cochrane database systematic review. And there was another one in 2010 that was also based on Cochrane database systematic review. That was by Henschke, and they found good results with that. So, a long time back in 97, when it started, with CBT, they found significant benefit with CBT in reducing the psychological distress, which we are actually looking at, in addition to improving the pain and improving the functions of these patients of chronic low back pain. So like that, but yes, there have been one or two negative reports also, negative outcome, one by Reed, where they had, but that was an uncontrolled pilot study in 2003, where they found that there was no difference between two groups, one using CBT, another one. They found initially good results with CBT at 2 weeks, but when they went on to 24 weeks, that means almost at 6-month follow-up, which is essential, they found the results were not significant. And same way, another one where they use, the rehabilitation. Actually, it's more of a part of comprehensive rehabilitation of discogenic pain patients. So, right. Thank you. Yeah. All right.
This is the picture of the treatment sheet. But sorry, we did not offer him a structured CBT session, but we have clinical psychologist. She evaluated him and counseled him accordingly. sure we can. I think we can start CBT later in our institute.
Okay. Okay.
Good morning, Dr. Devendra.
Yeah, good morning, ma'am.
We have already discussed about the pathophysiology, investigation, pharmacotherapy, and psychotherapy.
Yeah.
Now, I would like to ask you, how can interventions help this patient?
I would like to say, because chronic low back pain, and in that segment, to isolate the patient of discogenic pain is little bit difficult. As sir said, the therapies which Professor Saxena told the approaches, they are not basically for even plain discogenic pain, but they are usually combined low back pain without radiculopathy. So if we come to this point, okay, what are the interventions, how the interventions will help? So we have to determine, is this a low back pain of discogenic pain? That means if we perform a discography and see how much is the damage done to the disc, what are the level of degeneration the disc has, what you do a discography and post discography, the CT, and according to your Dallas classification, what are the grade of tear which the patient is suffering, whether there is a neural compression or there is a no neural compression, whether there are the somatic symptoms or the autonomic symptoms also. This all decide what intervention has to be done to relieve the patient's pain. Of course, first come the physical therapies and the pharmacological treatments for the neuropathic as well as other pain. Then
can you tell in this patient particularly?
In this patient, post discography, if you see there is a suppose there is a grade 1 or grade 2 tear, but in this patient, as I can see the post discography, the CT scan, the tear are of grade 3 and grade 4 level. They are complete annular tear, not exactly grade 5, not leading to the sequestration or the leaking disc into the epidural space, but they are definitely grade 3 and grade 4, involving the complete annular fragment and the complete, including the outer 1/3 of the annulus. So for these patients, intradiscal therapies like the nucleoplasties or the IDIT or the whatever the heating therapies are there for the nucleus, or if patient doesn't respond to these therapies, that may be a endoscopic decompression may be required. These therapies may help, but after the careful clinical judgment, then only we can apply these therapies.
So, sir, what are the ideal candidates for nucleoplasty or IDIT?
Can I share? I'll try to share the presentation. There are 2 or 3 slides. I'll try it. Pardon? If I open my PPT here, PowerPoint, then it will show it.
And then
Yes.
1 minute.
You have to, Dr. Devendra, you have to share screen. Yeah, share screen. Down, you are getting a green mark, share screen.
But I'm using my mobile phone. In it, I have a presentation.
So it's not possible with mobile phone.
Can I read out the?
Yes,
Yeah.
I'll read out because I have made something. See, if you are asking for the inclusion criteria for the nucleoplasty, I may say that the chronic discogenic low back pain with radicular symptoms are the criteria, and this should be the contained herniation, the adequate disc height of at least 50% of the normal, and if there is severe disc space narrowing and the large disc herniation, as it is seen in your patient in the CT post discogram CT, probably this patient is not a very good candidate for the nucleoplasty.
Okay. And anyone?
Because as you have seen the MRIs, there is a big degenerations and there are big annular tears
of grade 3 and grade 4, and because it is a not very well contained disc, so probably the patient is not a good candidate for nucleoplasty as per se.
I want to ask Dr. Dudeja sir, what is your opinion? Which is the best intervention you can offer to the patient?
See, basically, as everybody else is also saying, discogenic pain does not respond much to interventions. We have very few interventions, but if you look at the evidence-based medicine, most of these interventions have not yielded good results. So, and disc is one thing which we always consider it as a temple. So, I would not like to disturb the disc with lots of intervention causing more discomfort. What we have seen that if you are entering the disc and in the previous time, we used to put some steroid, we used to put some chymopapine and all those substances. But in that event, we used to have a lot of patients who developed discitis, and which was all the more dangerous because once you develop discitis, it was very, very difficult for us to treat. So that was one. So that was one. Somebody has put on the mic with a child. Please tell Devashish.
Devashish.
Devashish, please.
Dr. Devashish Mondal.
Switch off your audio, please.
Yes.
So,
admin can do it. Admin can do it.
As Dr. Devendra was saying, the best thing is to do a provocative discography. And if the provocative discography is positive, I think best thing is to send the patient to the surgeon, because he is the one who can fuse the disc and give you the maximum relief in that particular patient. Otherwise, the conservative management, whatever Dr. Ashok Saxena have outlined, are the best approaches to manage bad discogenic pain.
Thank you, sir. Now I would like to ask Dr. Subrata Goswami, what is your experience about the fast radio frequency of DRG in a case of discogenic pain?
So, based on our experience at our institute, sir, we are going to publish it very soon. We have done so far about 30 cases of nucleoplasty. After selecting with CT discography, and when we find that it is contained, when there is chemically or mechanically sensitive, and then it helps. So we had only out of these 30, only 2 cases of discitis, but it also resolved with conservative antibiotic within 3 weeks. And so, and about that, but it is a personal experience. I cannot say that this is an evidence in India. And also, DRG at L2, we have done DRG, and it also shown a good relief for more than 4 to 6 months each time. So reasonable relief. We continued the antineuropathic medicines and also the several sessions with the patients so that we could motivate, like that sort of. We did not ideally we did not do any CBT, that I must admit, but we that discussing the patient's own problem, educating the patient about the problem, and so the fear avoidance that helped a lot. So in this way, we could send majority to the work, because we are dealing with the patients who are manual workers mostly, and otherwise patients, it is very difficult to send them to work in the particular insurance-based hospital. They always seek for the sick leave or like that. But our result was better with nucleoplasty than DRG. It was our result.
Thank you, sir. Now I request Dr. Dudeja sir to summarize the case, as we are running a shortage of time, and share your experience and the challenges.
Certainly, but before I sum up, I think we have some, I'm keeping a track of the questions which are being asked. We have one, I think I'll ask the experts to answer these before we sum up this. And there are 4 or 5 good questions. One is from Saudi Arabia, Dr. Tapas, who says, is it permanent or curable, the discogenic pain? Any relations with food habits? And what are the tips for regular exercises to reduce back pain? Anybody can take this question, please?
Yeah.
Yeah.
Yeah, sir. I would like to say, if the question is that is there is any permanent cure, then I should absolutely say there is no permanent cure for it.
Absolutely.
Because it is a degenerative disc disorder, and as the age progresses, the degeneration will progress.
Absolutely.
Secondly, if you see the vascular supply and the supply of nutrition to the disc, there is only, because it is through the end plate only, and it is through the diffusion. So definitely the exercises, once you do the exercises in which the axial skeleton move, and there is a compression and decompression on the axial skeleton, then definitely it improves. It's like walking and jogging. It improves the vascular supply of the end plates and the nutrition of the disc. And smoking, I suppose it decreases the peripheral supply and the supply of the end plates also. So these are some factors which can increase the degeneration, the diabetes, the smoking, and the lack of exercises. These will increase the degeneration of the disc and will cause more and more problems. And if you avoid these, probably it will be better.
So, Dr. Devinder, you said it right, but you can also add that yes, we have an option of disc replacement. It's a very expensive procedure, but yes, disc replacement is also one option which we can think about.
The evidence is there of disc replacement, but more of a cervical region where the mobility is more.
Yes.
In the lumbar region,
just like Shah Rukh Khan had a disc replacement and is doing very well.
Cervical it's better.
Yes. So the second question is from Pramila Arora, who is asking about new modalities for management of disc pain. I think Dr. Subrata has already mentioned about nucleoplasty and DRG or radio frequency. Then there is one question, Dr. Saxena, for you. Can you sum up the mnemonics of A, B, C, D, E, F, and W in very short time, please?
Well, yeah. A was for attention. As I said, anxiety has attention to pain.
Yes,
E for behavior, and C for compensation. Are they seeking a claim from insurance companies? And so that kind of thing, is very important. Then W was for working. Is he off work? Or is he in job? Then F was for family. Family support missing, or it is. Are they pampered by the family support? Sometimes it happens like that also. So these are the things A, B, C, D, E, F, W, which are important. And we need to rule out those yellow flags.
So we have another question from Sunita Lavange, which she's asking about your experience with CSQ, which is a tool for assessing the cognitive coping strategies. Have you got any experience with that?
Well, all that I can tell you is that I've been using, Becton depression inventory, and we have been using Roland questionnaire. I have no experience with the one which we are talking about. We are using mostly the Roland questionnaire.
Fine. One more question from Kolkata. Any role of PRP before opting for more invasive procedures?
Well, at least I don't have. Maybe someone else can add.
Yes, but there are a lot of studies being done in US, and they are reporting. Of course, they are not randomized control studies, or they are not proved the evidence. But yes, there are studies which are going on about the role of PRP in discogenic pain, and they are claiming good results. But definitely, we cannot sort of advocate now. There is one question from Nepal. They are asking about role of L2 sympathetic block. Anybody can take that. I'll just take one or two questions more, please. Anything, Dr. Devinder?
Can I?
Yeah, please.
Yes.
Yeah, sir. Role of sympathetic block is reserved only in a few patients where we see the evidence, or we can diagnose complex tissue pain syndrome due to the discogenic pain, or a sympathetic element is there. So if it is sympathetically mediated pain, then there is some role, but reaching to the diagnosis of sympathetically mediated pain is very difficult. So we have to.
So I think the time has come to sum up, because otherwise we'll be running out of time. And I think we had a very good case discussion on discogenic pain. And I would, whosoever the young pain physicians who are watching this webinar, I must tell you, it's very important to take a detailed history and do a good examination, because the success of your management is your good examination, good history, which will clinch the diagnosis. And then you have to weigh the options depending upon the facilities available to you. But as said by most of the speakers, that conservative treatment is the best treatment if you have diagnosed. If you are in doubt, you can do a provocative discography. interventions at the moment have doubtful role, but definitely change of lifestyle, exercises, no smoking, proper nutrition, all those have a very, very important role. So now going to the second module of this very interesting webinar, we have people from all across the globe who are attending, people from US, Saudi Arabia, Middle East, Bangladesh, Nepal, and name any country. So the second module which we have is to be conducted by Dr. Just let me have a look, sorry. Which is to be conducted by Dr.
Aragya.
Dr. Aragya. Dr. Aragya Mukherjee. Yes, Dr. Aragya Mukherjee will be talking on vertebral compression fractures. As I said, very, very important topic. And over to Aragya Mukherjee for carrying on. And please try to restrict it to half an hour so that we can have good time for discussion. Dr. Aragya, please.
Thank you.
We have the speakers who are there, or the panelists who are there. I'll just name a few of the panelists who are there. Dr. Can you just name the panelists, please? Yeah. So we have Dr. Babita Ghai, who she's a professor of anesthesiology and pain medicine at PGI Chandigarh, and she has been really doing a lot of pain work, research work, and clinical work at PGI Chandigarh after having a stint at All India Institute of Medical Sciences, New Delhi, and she's presented a lot of papers also on pain in various world congresses. Dr. P. Vijayananda, he's a consultant at Atlas Pain Care Center in Coimbatore. Earlier, he was in Hyderabad managing the traveling pain school, but now he is a director of Atlas Pain Care. We have Dr. Anurag Agarwal, who is a consultant pain physician at the Dr. Ram Manohar Lohia Institute of Medical Institute in Lucknow, and he has been instrumental in establishing pain clinics at Medical College Meerut, Medical College Kanpur, and now he's at Lucknow. And finally, we have Dr. Prasad Kasliwal, who runs his own Pushp Hospital, which is an international pain management center. He's a fellow of the Indian Academy of Pain Management, fellow of fellowship in chronic pain, and we have all these elite panelists who will be discussing this very important topic on vertebral compression fracture. Over to Dr. Aragya, please.
Thank you, Dr. Dureja, for your nice introduction and kind words. And I welcome all the panelists. So the time is short, and I will be requesting all the panelists to keep their answers crisp and short, so that we can quickly pass on to the next question. Because we have two case scenarios here. Before starting case scenario, or before coming into the vertebral fracture, let's see about the structure of the vertebra. All we know, it comprises of body, superior and inferior articular process, transverse process, pedicle, and the spinous process. But the important structures here are the posterior ligamentous complex that comprises of supraspinatus ligament, interspinatus ligament, ligamentum flavum, and the facet joint capsule. And coming to the different classifications of vertebral fracture, we have age-old Dennis classification and then followed by AO classification. But nowadays, the most important is this one, TLICS, thoracolumbar injury classification and prognostic. And these are the nowadays the most important classification, because it gives importance on morphology, integrity of the PLC, and the neurological structure as well. And it indicates the requirement of surgery as well as the prognostic indicators. And according to morphology, we have compression fracture, burst fracture, translation or rotation kind of fracture, and distraction kind of fracture. Among all these, we today only focus on only compression fracture. Compression fracture actually fracture of the anterior 2/3 of the vertebral body, mostly the upper part involving the upper end plates, but sometimes maybe the both or the inferior plates also. Now coming to first case scenario. Mr. Gupta, a 66-year-old male retired patient. He was doing gardening, and while he felt severe pain in the middle back, and pain was sharp shooting in nature and radiating towards the abdomen, aggravating more on the forward movements, and then he was attended to by a local doctor, who prescribed some medication, but it was not relieved. At night, when he was trying to lie down, the pain aggravated to very severe condition. He was rushed to a hospital, admitted through emergency, and landed in ICU, where he was prescribed some intravenous medication, which relieved him a lot. He is diabetic, hypertensive, as on medication for the same. The next morning, when I was called as a pain consultant, I found he is conscious, alert, oriented, of good health. His pain score at that time was 6/10 of NRS scale, and site was middle back, character was sharp shooting with some radiation, aggravated by forward bending. Neurological exam was mostly within normal limits. X-ray and MRI both showed a compression fracture at L1 only. All the other investigation were at normal limits. Medications, that time patient was on paracetamol 1 gram intravenous 3 times daily, intravenous fentanyl infusion 50 microgram per hour, paroral pregabalin 75 milligram twice daily, and aceclofenac 100 milligram twice daily. And this was the clinical picture, rather MRI, where we can see visibly there is a compression fracture at L1. Now my first question to Dr. Babita. Good afternoon. Already this is afternoon. So my first question to Dr. Babita, what may be the cause of this kind of fracture?
Good afternoon, Aragya. Thank you for summing up the case report. I will be crisp that the causes of compression fracture can be because of one, there is an excessive pressure on the vertebra in a healthy vertebra. Two, the vertebra is weakened, or the combination of both. So if it is a healthy vertebra, like in a young patient, then trauma is the most common cause. And usually, like in this patient, which you are summing up, the cause seems to be the combination of both. That the vertebra, there is a pressure which is maximum during the forward bending and downward pressure, so which he was gardening at that time, and probably he also has a weakened vertebra because of either the osteoporosis or osteopenia. He is 67-year-old. So diabetic as well as hypertensive. All this point towards that he already has a weakened vertebra, so he has a combination of both the pressure as well as the weakened vertebra. Another causes of compression vertebral fractures are metastatic disease of the spine, infection of the spine, and probably multiple myeloma. So this is to sum up the causes of compression fractures.
Thank you, Dr. Babita. That's all the kind of you answered. And now the next question to Dr. Prasad. What are the management options we have, and what are the medication can be used for immediate pain relief?
Okay. Management options, actually we divide in two parts. First one is for fracture management and second is for osteoporosis management.
Correct.
And in case of fracture management, it will depend. As you said, MRI seems to be spine. If spine is stable in the MRI, and as height loss is not more than 30-40%, we can, and if pain is not severe, we can go for conservative management like immobilization, rest, analgesics like NSAIDs, opioids, and back brace, diet, and stop smoking, alcohol if anything patient is taking. And simultaneously for the osteoporosis management, we have to go for the calcium, vitamin D supplements, bisphosphonates, and along with that we can go for the parathyroid hormone like teriparatide and all. And we should keep on following the follow-up X-ray of the patient. If there is a progressive wedging of the vertebra, progressive vertebral collapse, in that case, we have to think about the minimal invasive procedures like vertebroplasty or kyphoplasty.
Okay. Okay. Sir, I would like to ask you, in this particular case, patient was in ICU at that moment, and patient was on fentanyl infusion along with NSAIDs and pregabalin. So, what do you want to do? I mean, shifting the patient to ward, and what are the medication changes you want to do in this case?
Okay. In this case, if we do immobilization, we give back brace and all. And if patient feels comfortable, then we can go for the conservative. But if patient is not getting any relief, then we can go for the intervention.
Okay. I would like to ask Dr. Dureja if on the view that if early vertebroplasty can be done.
Depends on the level of osteoporosis. If it is not a very severe osteoporosis, because if these are elderly patients, he's a 66-year-old patient, I don't want to be let him lie on the bed for a longer period because of the weakening of muscles. And if you feel that this fracture will take long time to heal, then I think we can give him an option of an early vertebroplasty, which will help him in early mobilization and good relief in pain. So on my part, I think I will give him an option of an early vertebroplasty.
Thank you, sir. Thank you for your opinion. My next question to Dr. Anurag. What are the prerequisites for vertebroplasty in this particular patient? Or rather, you can elaborate slightly, what are the total prerequisites before doing vertebroplasty?
After that, thank you for inviting me and having me here. In this particular patient, if we talk about the vertebroplasty, I would suggest to go. I would like to add one thing in the investigation part, that as is the elderly male, I would like to have his serum PSA checked, just to rule out any involvement of prostatic malignancy, to be on the safer side. For this, his current condition, I would suggest, and I would like to go for the early vertebroplasty only, not even the kyphoplasty, because vertebral height is good. And I do not want, as Dr. Dureja rightly said, that we do not want our patient to be bed bound for long, because that will otherwise worsen his condition, worsen his osteoporosis, and it is not of any use. So I would like to treat this fracture of vertebral bone as any other fracture of any bone in the body, like the femur fracture, like the tibial fracture, where we usually like to fix it as early as possible. So for the prerequisite for this patient going for this thing, not much. His blood sugar, I would like to be controlled, as he is a diabetic patient. Hypertension should be controlled, and one coagulation profile is required, and that's it. This is a minimally invasive intervention, not going to have any blood loss under local anesthesia. So I think that should suffice the things.
Yeah, sure. Thank you. My next question to Dr. Bijanan. What are the possible mechanisms of pain relief by these minimal invasive procedures?
Yeah, that's the $1 million question, isn't it? No one knows. That's a straightforward answer. Now, I think cement is causing the pain relief by solidifying.
Sir, can you speak louder, please? We cannot hear.
You can't hear. Okay. Can you hear me now?
Yeah.
Okay. Now the thing is, if we think is the cement which is causing the pain relief, now the possible mechanism could be it is stabilizing that part of the spine. Now we also think in terms of thermal necrosis, some pain relief. We can think of chemical destruction of surrounding that area, which can cause pain relief. And more interestingly, there is this VERTAS-4 trial, which was published last year in the British Medical Journal, looking at vertebroplasty, comparing it against sham procedures. And they say that just putting some local anesthesia where the trocar went in produces equal benefits. Now, I'm not saying it's great, and I agree with both Dr. Anurag Agarwal as well as Dr. Dureja in offering early vertebroplasty to this particular patient who might benefit immensely from it. But in terms of how these procedures work, I don't think there is a definitive answer for that. There are multiple mechanisms involved, and I don't know, or we don't know, which plays a more prominent role in bringing about the pain relief. So I think that would be my honest answer.
Thank you, sir. Dr. Anurag, you want to say something?
Yeah, as Dr. Vijayanand has rightly said, that there are quite a lot of controversy about the role of vertebroplasty, whether it works or it doesn't work. But my take on this thing is that there are controversies of practically every and each treatment which have been offered in the allopathy. You can have papers on for and against to everything. As far as the mechanism is concerned of the pain relief, one I believe is the fixation of the fracture. Second is heat generated by the cement, and other things Dr. Vijayanand has already told.
Okay, thank you.
Yeah.
Thank you,
And,
sir.
I would like to add one line. Like it has been said that every viral infection, like the flu, gets treated with or without treatment within 1 week. Still, we treat it. We do treat it because we want to prevent the morbidity. So is the case with this kind of fractures. They may or may not get healed within 3 months of bed rest, but we do not want our patient to get suffered for 3 months if we can help them.
Yes, of course. Thank you. Now, there is a question, a comparison between kyphoplasty and vertebroplasty, and we all know, and this is for the beginners. In case of vertebroplasty, they put a cannula and needle through it and put the cement inside the body of the vertebra. While in kyphoplasty, they put a balloon through the cannula, inflate that balloon, then deflate it, remove the balloon, and then put the cement inside the cavity. So my question to Dr. Babita, which one to be done in this case? I mean, which is more effective?
Thank you, Dr. Aradhya, explaining it very nicely. What is vertebroplasty and kyphoplasty, especially for the beginners? So if the beginners are understanding that kyphoplasty is basically passing a balloon and creating the height of or increasing the height of probably a decreased height of the vertebra. So in a decreased height vertebra, you put in balloon and increase the height. So if we talk about the indications for kyphoplasty and vertebroplasty, they are usually same, barring the decision is that if the vertebral height is preserved, like in this case, then vertebroplasty is the choice. Can you hear me?
Yes, yes.
Yes. Okay. And if the height is reduced, then we can go for kyphoplasty. But there has been evidence about using both the modalities in the similar situations where the height is also preserved or vice versa. And the evidence is different. The evidence has come up about pain and disability assessment is usually same between vertebroplasty and kyphoplasty. Some evidence say maybe vertebroplasty is better. Some evidence say maybe kyphoplasty is better. But most of the time, as far as pain relief and the disability, the results are usually similar. However, the chances of complication is reported to be lesser with kyphoplasty. That is a lesser cement leak, better preserved height of the vertebra, and less, I think as far as the complication goes, the lesser cement leak is the major concern, which is reported with kyphoplasty. So the choice between vertebroplasty and kyphoplasty is patient dependent and also differs from case to case. In this case, I would like to go for vertebroplasty rather than kyphoplasty.
Thank you. Dr. Dureja, sir, can you add something to this? Dureja, sir? Okay, quickly.
Aradhya, we can take opinion of others who have more experience in
yes,
vertebroplasty and kyphoplasty.
Dr. Anurag, will you add something?
Yeah, actually, Dr. Babita ma'am has already summarized as well. But still, I would like to say one line that vertebroplasty is said to be the surgeon's answer for vertebroplasty. Well, kyphoplasty has been said is the surgeon's answer of vertebroplasty. Actually, vertebroplasty was discovered and invented by a radiologist and embraced by the pain physicians world over.
Yes.
So, kyphoplasty is nothing but vertebroplasty. You are just creating a space and then filling the cement.
True.
But it is there is a cost to this thing also, that you are increasing the height supposedly, which doesn't stay as such in the later on studies. So there is blood loss is certainly more with kyphoplasty. Kyphoplasty is very costly in comparison to vertebroplasty. So otherwise, pain relief and everything is same. There is not much difference. Now there are other options also, like the spine jack. There is one option like the vesselloplasty. So too many.
Sir, we will come into that. There is another question for
I will also like to add something. It also is also
Yes,
based
sir.
on your personal experience. See, once the posterior cortex is breached, I think one should not attempt a vertebroplasty. And normally we consult the radiologist, or we do a CT scan before we do the vertebroplasty, and we make sure that the posterior cortex is not breached when you are planning for this. And I think a couple of years back, to my bad luck, we had a patient where I specifically talked to the radiologist, got the CT scan, and there was no breach in the posterior cortex. But while doing vertebroplasty, I could see a small streak of the cement going into the epidural space. And that was the time when I decided that I will go for a safer option. So I have converted most of my patients to kypho rather than vertebroplasty, based on a very anecdotal experience of a leak of cement from the posterior cortex. But as everybody has said, that if there is a breach, one should think about a kyphoplasty only. But otherwise, both are safe and both can be done. It is expensive, but you feel safe when you do a kyphoplasty. Thank you.
Thank you, sir. Quickly move on to next case. This is a bit complicated. A 71-year-old man suffering from multiple myeloma and had been receiving chemotherapy for last 5 years. He is hypothyroid, hypertensive, and some ischemic heart disease also, and on medications for those things. The emergency, and when I called again as a pain physician, I examined and saw a patient with a poor nutrition and a poor general condition, semi-sitting posture. He can't lie down properly flat on the bed, and pain score was that NRS scores were 8/10 at that moment, with more pain on the whole back, although mostly on the middle lower back, so much so that he cannot lie down, and he is in that position for last 2 days. The pain is sharp in nature, and there is a bilateral radiation to both legs, more on the left in this case. And power on a further examination, we could not do the full examination as he cannot lie down flat on the bed. The power on the left leg was 3/5, whereas on the right it was 4/5. Both sensory and reflexes were normal, and there was no bladder and bowel involvement. Patient was on etoricoxib 19 milligram OD, pregabalin 75 milligram twice a day, intravenous paracetamol 1 gram 3 times daily, fentanyl patch 25 max per hour, and the tramadol 50 milligram IV 3 times daily. Investigation: hemoglobin was 7.6, creatinine was 1.6, WBC was 13,400, CRP was 25, sodium potassium also was within almost normal, and calcium also a little bit high because of multiple myeloma. X-ray shows multiple level vertebral involvement by this disease, the myeloma, like D7, 8, 10, and 11. But there are compression fractures at L3 and L5 with and chest X-ray shows bilateral basal collapse. So my first question to Dr. Prasad: what medication further we can add so that the patient MRI can be done? Because everybody, including the relatives, were afraid of general anesthesia for MRI. Dr.
Okay.
Prasad.
Yeah. As we regularly do see patients with multiple myeloma. In this case, most of the medications you have added, I would like to add steroid in this case. Steroid will reduce his swelling and inflammation and help the patient to lie down in MRI. So most important is steroid. And as the patient is on chemotherapy since 5 years. And in case of multiple myeloma, if patient is on chemotherapy since last 5 years, he must be resistant to that chemotherapy agent, and he need to shift on another chemotherapy agent. So for that, you need to add steroids like dexamethasone from 20 to 40 milligram per day, and simultaneously change his anti-myeloma drugs. And if once the patient get within 24 hours get settled, we can shift him to MRI, so that without anesthesia we can do the MRI. Aragya, doctor.
Yes, yes, thank you. Dr. Anurag, do you want to add something?
No, I think I agree with him. For pain management of this particular patient, I think that
Now, before
calcitonin
doing MRI, we have to add something so that patient we can perform MRI without GA.
because you want to optimize your patient, you don't want to give any anesthesia. So along with steroid, I would like to add the calcitonin also in the nasal spray form. That also works very well for the bone pain in these particular patients, subset of patients with bone pain.
Okay.
Can I?
Yes,
See,
ma'am.
the steroid and calcitonin would take some time to act.
Exactly.
I understand that, Aragya, probably your question is that we have to take this patient to the MRI suite.
No, ma'am.
Yes.
Read the second line also. Actually, that is the crux.
No, agreed. But question is that we want to take the patient to the MRI suite, so we want to perform MRI without general anesthesia.
Yes, yes.
So we need to add on minimally sedative agents, or maybe some more thing which can reduce his pain and give him movements. Adding steroids and calcitonin would be helpful, but it would take some time. So how are you planning to perform MRI and taking him to the suite if you want to do it early?
Exactly, ma'am. That was the question.
So I missed out. I think the patient is on fentanyl infusion or something.
Fentanyl patch. Patient was on fentanyl patch, 25 mics per hour.
Okay, so we can think of giving some IV opioids, short acting. Fentanyl is a good choice. If we have availability of remifentanil, that infusion can also be used. But we have to be careful about it.
Can we give some ketamine? In an analgesic dose?
Sub-anesthetic analgesic dose, but we have to be careful. Patient is cachexic, and even the sub-anesthetic doses can lead to some sympatholytic effect. Sympathomimetic effect. And other thing is that hallucinations, even with the sub-anesthetic doses, is a concern with ketamine, especially in poorly nourished or cachexic patients.
Dr. Aragya, we have to rush up. Dr. Aragya.
Yeah.
Yes.
Yes.
So MRI was done, and we found. So we found multiple level compression is there in MRI. So my question to Dr. Hello, I am audible?
Yes, please. Go on. Further.
My question to Dr. Anurag, which level should we perform this minimally invasive procedure? And how to decide when we find this kind of multiple level compression fracture?
Yeah, look, there is one picture. I think that this is the second picture is the STER image, T2 image, fat suppressed T2 image. So here you can see that there is a edema or a high signals in the, perhaps this is L4 or I don't know, it's L5, the lowermost vertebra which is being compressed, and also at the upper level. And here is the L1 level where we can see a cleft, and it's very difficult to find out exactly which level to be done. But what I do personally, I tap the patient's back with my hammer, and wherever it is the most tender, I would like to go. And second is that the radiation of pain. Like in your patient, this is a slightly complicated picture. Usually what we see in this kind of patient, the patients are unable to sit because of the fractures in the thoracolumbar region. So I would like to do maximum 2 to 3 level or 4 level perhaps in this patient, especially this last one, and this perhaps this is 5, 4, 3, 2, 1, T12 perhaps. I would like to go for these 2 level at least.
Okay, thank you, Dr. Anand. The next question to Dr. Bijanand. What is your opinion regarding early and late? We were discussing something like that earlier. Early and late augmentation kyphoplasty. That time it was vertebroplasty. Now we are augmentation kyphoplasty.
Okay, yeah. I think it's purely based on clinical judgment with regards to what is required. Now, this if it is a osteoporotic fracture, my considerations would be different. Now, this is someone with malignancy, and here we are looking at a quick, safe, and effective analgesia. So if at all you want to err on doing an early augmentation kyphoplasty rather than a late one. Now, if you look at evidence for any vertebral augmentation procedures, I think the opinion when you want to do it, either immediately or 2 weeks later or 4 weeks later, there is a big difference of opinion and debate. For instance, the American Academy of Neurosurgeons, they want to do it after 3 weeks, whereas the New Zealand and Australians, they want to do it after 4 weeks, whereas there are certain groups who believe it should be done immediately rather than going with conservative management. But given the situation, given this particular problem, patient with malignancy, or on the side of going in for an early kyphoplasty rather than a late kyphoplasty.
Okay, thank you. Now, next question, it was Dr. Anurag was telling the future scope or modification of minimally invasive procedures. Sir, I would like to ask Dr. Anurag only, what is your standpoint in this case?
For the vertebroplasty thing?
Yeah, the scope of minimally invasive may be kyphoplasty as well.
Yeah.
Vertebroplasty, both kyphoplasty and
yes. Yeah, for the vertebral augmentation. Yeah,
yes.
A lot of things are happening. Like there is one vesselloplasty where you leave the balloon. There is a perforated balloon. You leave the balloon inside the vertebra after inflating it, and you remove the rest of the part, and you fill that balloon with the cement, and that makes a spikes through that perforated balloon. So that supposedly take care of the cement leakage problem because it makes a ball sort of thing inside the vertebra. Then there is a spine jack thing which has been, but I don't think the spine jack is available in India, but vesselloplasty is available. I haven't used it, again, cost considerations. Mine is a government setup, so I don't use much of these exciting things, but yes, they can be done.
Okay, thank you. The last question to Dr. Babita again. Shall we pain physician alone perform this kind of procedures?
Dr. Aradhya, this is a very burning topic, especially for we as pain physicians. I will say that most of the guidelines, in fact, first I'll say my own opinion, that is that the pain physician, if they are in a standalone unit without any backup support of a neurosurgeon or orthopedician, in a standalone unit, it should not be performed. If there is a backup, so while I would take this question as two questions, like should we do practically this procedure as alone? Yes, we can do this procedure if with adequate training. That means we do not need help of a neurosurgeon or an orthopedician. If we are adequately trained, we can do this procedure. But should we do it in a standalone unit? No. We should not do it in a standalone unit. In case we get into any trouble, if there is a cement leak or if there is unmanageable situation, we must have a backup support. In fact, it is always a good start to have your colleague in confidence. You do not need a neurosurgeon available in hand, but standing with you. But yes, you should always inform a neurosurgeon or your colleague orthopedician to be that while you are performing this, that in case of need, if need arrives, he should be available and he can be called.
Thank you, ma'am. I would like to ask Dr. Dureja to add to this and sum up the session.
Well, I don't agree with Dr. Dr. Babita
I know.
about this entirely, because this is our bread and butter. I keep calling neurosurgeons for this, then I'm not a pain physician at all. So I would not. I'm a standalone pain physician. I have standalone clinics, but I don't call neurosurgeons. Even for my pumps and stimulators and kyphoplasty, I don't call neurosurgeons. I've never called a neurosurgeon. Even when I was in All India Institute of Medical Sciences, I never called a neurosurgeon, because yes, of course, it is your learning curve. If it is steep, fine. But if you learn it well, and if you know the complications, if you know how to manage the complications, I think you are fair enough to, you should be doing without any help. And there are no major things which, I mean, like it is like a simple, what do you call as MIPSI, minimally invasive pain spine intervention. So we don't have to, if you know your theory well, if you know your practical well, and if you know the complications and management well, I think you can manage it. We have a lot of questions on this. I can't take all the questions, but please be ready for the questions. Somebody has mentioned don't use remifentanil because it is very dangerous. Fine, accepted. Dr. Anamika is asking about if the leak of cement happens to epidural space, how to go about it. Anurag, if the leak goes into the epidural space.
Yeah, there it should not happen. It should not happen when
Should
any.
not happen.
Yeah, and you have to take care, as you said, sir. In your case, you have to take all the cares. And the single most two important points I would like to add here for the my pain physician colleagues, that always use cement meant for vertoplasty or kyphoplasty. Do not compromise with the
Yeah.
cost. Do not cost cut. Do not use the normal cement, because that doesn't give you adequate time. That keeps you on as before, that you want to fill it early before the cement gets hardened.
Yes,
Second
absolutely.
thing,
Yes.
the single most important factor which will save you from the cement leakage is the live fluoroscopy and the lateral picture while you are
Absolutely.
injecting it. The single most. If you take care of these things, then, and third thing, then small leakage, as unfortunately happened with sir in his case, because he was looking at doing it under live fluoroscopy, he just immediately stopped it. You
Stop.
need not worry anything. You need not do anything because God is great. So
Yes, yes.
these two things I would like: good cement
Yes.
and live fluoroscopy in the lateral picture.
Yes.
That's
So
it.
you should not be restless. You should see the
Yes,
consistency
sir.
of the cement, and then
Exactly.
only start injecting. And a live fluoroscopy, even if it takes 10 minutes,
Yeah.
live fluoroscopy in the lateral view
In the
is a must. And
must.
once you're seeing, because I saw just a streak and I stopped.
So,
The streak is still there, but it did not cause any neurological deficit. So
because sir,
you
I
have to
would
be careful, but obviously it can happen.
yeah,
I mean,
it can.
in spite of me talking to the radiologist and confirming again and again, it happens. So
Sir,
that is
if
one.
it
So don't
happens,
be-
the question is, if it happens, okay, forget
Yeah.
a streak, you had been very experienced. If it happens, more than a streak, what should we do?
If there is a
then you have to wait and
neurological
watch. Yeah, please, Anurag, go ahead.
if there is a neurological compromise, then it has to be decompressed, open and decompressed. Then you need a ortho spine surgeon or neuro spine surgeon who will come and open it and do it. There is no
So
other way around it.
that is the only thing which I fully agreed with sir, that in the initial learning phase, we must have a standby. That is the only thing which I want. We can do this procedure alone.
Yes.
Okay.
Actually,
I mean,
it is like the cardiologists, na? They always have a backup of the cardiothoracic surgeon.
CTBS. Exactly.
So it
That's
is
it.
like that. This goes with all the minimally invasive branches.
Fully agree. Fully agree.
Gastroenterology.
Okay.
Any
So
other questions, sir?
I think we are running out of time, so we'll end up this discussion, which was fantastic.
Sir, we
and
can answer the questions later on after the end of the
Yes,
session
yes.
and
If
through
we
the
have
chat.
time-
Through the chat.
If we have time, we will definitely through the chat also. But if we have time, we can go for this. So
Sure,
we
sure,
are moving on to the last module of this very important webinar, which is a post-laminectomy syndrome. And we all know, as pain physicians, that what a challenge it is to manage post-laminectomy syndrome once they come to us. We have Professor Ashok Saxena. I've already introduced to you. The Debulina Ghosh. She is a pain physician in Kolkata, and she's also an alumni of ESI Institute of Pain Medicine. Babita is also a part of it, and Anurag also part of it. Gargi Nandi is the moderator, and I would request her to please start as early as possible the next module.
Thank you, sir. Now, with the permission from the chairperson, the last case discussion on post-laminectomy syndrome. Again, this is a real patient. I have just changed the identity. Mr. Roger Roy, a 35-year-old jute mill worker, admitted under in department on 1st October 2019, complained of pain in the lower back and right leg. Patient was undergone a transpedicular stroke 3 years back following a fall in the jute mill. Gradually, he developed low back pain after 1 year pain-free period of surgery. He was restricted to lower back only, but last 1 year, he is suffering from right leg pain up to grade 2. The type of pain is like electric shock, time of walking and sitting, and by supine position. His sleep is disturbed. He is suffering from insomnia. Bladder and bowel habits are normal. He did not complain any loss of sensation or loss of power in lower limbs. His pain intensity is 8 in NRS score, which leads him to be admitted. He is very much depressed. Now coming to the physical examination. In inspection, a 6 cm scar is present in the midline. On palpation, tenderness is in the bilateral L3/4 facet area. SLR is positive at 45 degree in right side. Patient experiences pain during flexion, extension, and lateral rotation of spine. Now, I would like to welcome Dr. Debolina. Dr.
Gargi. Good afternoon, Gargi.
Good afternoon. Good afternoon. So, what do you think? What may be the cause of pain in this patient?
So, this patient had a history of laminectomy 3 years back at the L4, L5 level, and at present he is complaining of L3, L4 facet joint tenderness is present. So, mostly maybe there is facet joint arthritis. We have to exclude or establish this thing by doing facet joint diagnostic block. Now, on clinical examination, we have seen that this patient is having restriction of range of movement in all the planes. Okay, so this may be the myofascial component is definitely involved here, and all the paraspinal muscles, even sometimes the hip muscles come into play and they have gone into spasm. Now, the patient is also complaining of or having the pain in the radicular distribution along the L5. So maybe there is transforaminal scarring present, and maybe there is L4 or L5 disc herniation with lateral compression on this exiting L5 nerve root. So these are the causes.
So the provisional diagnosis is the patient is suffering from post-laminectomy syndrome with bilateral L3, L4 facet joint arthropathy and right L5 radiculopathy with involvement of the muscular component, facial component. So, what are the other causes of pain in post-laminectomy pain syndrome?
Well, in that case, I must mention one thing that post-laminectomy or failed back surgery syndrome, what we say is a misnomer, because it doesn't mean always that the surgery has failed or the surgeon has incompatible or this thing. So the thing is, there is complete difference in the biomechanics of the spine got altered. So this causes the internal disc degeneration above or below the fixed segment may happen. Spondylolisthesis or spondylolysis is not very uncommon, and we must have to exclude some infective causes also, like discitis, epidural hematoma, or abscess formation. And coming to the surgical causes, it may be due to instrumentation problem or wrong level surgery, or maybe surgical inexpertise in some cases. Now, I want to mention one thing, that preoperative history taking or our history taking as pain physician is very important, because see, this patient was a smoker. So smoking and obesity are very important predisposing factor for FPSS. And one more thing, psychological evaluation is also very important, because depression, hypochondriasis, or difficult coping mechanism, all this may prognostically lead to this FPSS or post-laminectomy syndrome.
Is there any data available which shows the actual incidence of post-laminectomy pain?
Well, there are so many studies are there, and they are showing, and it is published in various reputed journals like BJ, Spine, Neurosurgery, and they are showing it is a varied incidence, like 10 to 40%. But recently, in 2017, in Japan, they have made one study. It was an internet-based study. So they have shown the incidence is around 20.6%, mainly focusing on the residual pain and the satisfaction level of the patient post-surgery. And in this study, they are clearly mentioning that more the surgical levels and mainly the fixations are more developed this FPSS than single level surgery or decompression surgery.
Now, which is the actual incidence of pain?
Sorry?
Is there any data available in Indian scenario?
Yet not. I have found any such kind of data in Indian scenario. Maybe the other dignitaries can, if they know that, then they can join. And
now, thank you for the nice deliberation. Good afternoon, Dr. Ghai, madam.
Good afternoon. Good afternoon, Gargi.
Gargi, can I interrupt you for a minute? Yes. I have your provisional diagnosis is little incomplete, because this is for everybody who is listening, the younger pain physicians. Post-laminectomy syndrome with bilateral facet arthropathy and right L5 radiculopathy. You should also mention with cognitive behavioral deficit in terms of whatever the patient is having, because this is one syndrome where that carries a major role. So if in your provisional diagnosis you have evaluated the cognitive behavioral scores like depression, anxiety, and if you also mention, that makes a lot of credit to you, because that would be the complete diagnosis, not just facet arthropathy or radiculopathy, because you may do anything to the facet or patient will not get relief, and you know why, because there is a pre-existing deficit with behavioral deficit or anxiety or depression which is causing. So in your diagnosis, if I am seeing my patient in my OPD slip, after this I also mention with depression, anxiety score or whatever deficit patient has. So sorry about interrupting. Continue.
Not at all, sir. You've always, thank you, Gargi. Sir, you have always been pleasure to hear about, yes, sir, I fully agree. Gargi, I just want to get clarified that if this patient has pre-existing cognitive behavioral disease before the laminectomy as well, or developed after the laminectomy?
He developed after the laminectomy.
So it is the impact of the post-laminectomy syndrome. So it is the impact of chronic pain now, which has led to the depression. Am I right?
Yes, ma'am.
Because this is very important. If surgeon would have chosen a patient with a yellow flag sign or with a pre-existing cognitive behavioral patient, then his surgical outcome also varies. Then he has the higher chances of getting a patient who has a post-laminectomy syndrome. Okay, so coming to my question, that what are the investigations? I would say we will go for radiological investigation as of a static pain radiographs to check for the spine alignment, flexion and extension views of the radiograph, both lateral and AP, to check for any instability. CT scan would be of help to check for any bony surgical defects, hardware placement as this patient has screw fixations, and to check for any fusion mass. MRI would be helpful for checking any soft tissue or the neural structures defect. And if required, then radionucleotide imaging, that is technetium 99 bone scan or indium 112 WBC scan, which may rule out any infective or inflammatory pathology, but definitely not a choice usually being done. But that is just to add up to the list. And basically the CT scan or the ABAP4, like static flexion, the movement X-rays, CT and MRI would tell to detect whether it is again a surgically correctable pathology like a huge sequestrate mass, or whether it needs definitely the multidisciplinary pain management would be required, whether it is a surgically correctable or surgically non-correctable pathology. But to add on to that, whether the patient would need any minimally invasive further treatment. Another investigation which is of help, which may not change the therapeutic management, is EMJ study, which you have already got done in this patient. This is basically to establish the presence or absence of peripheral neuropathy, or distinguish between the peripheral versus central neuropathy. It may be also to help in defining the subclinical neurological deficit, but this patient already has clinical deficit, and but it is rarely helpful in making the decision regarding the treatment. About further investigation is that diagnostic blocks. So as you have already done diagnostic block, rationale is really a straightforward. In practice, it is more complicated to do diagnostic block, because usually one single block, positive or negative, has a high error rate. So we should be performing at least 2 diagnostic block, and placebo control provides more accurate information, but using 2 multiple blocks with different agent may also be helpful. You have already performed 2 diagnostic blocks, probably it was 2 weeks apart, it was 2 days apart, you know? 2 days apart. So it tells you about more about the precision diagnosis of what you are thinking. If you have used facet joint block or you have used SIJ block, whatever you have used, if it is 2 blocks which has positive rate, especially with different user agent, then it is very helpful. So I believe this completes my investigation parts.
Thank you, ma'am. Then what are the medications would you like to give this type of patient?
If you go by the history, then it has both component, nociceptive as well as neuropathic component. Okay, history and physical examination. So patient would need both coverage of nociceptive and neuropathic pain treatment. Professor Saxena has already very elaborately covered neuropathic pain medication. You have already been prescribing neuropathic pain medication. Like usually the first line management is gabapentinoids and a combination of amitriptyline or nortriptyline, a TCS. Second line management may be duloxetine or venlafaxine. So this is, and nociceptive pain management by using paracetamol as either on the SOS basis or tramadol if required. So this is coverage of nociceptive as well as neuropathic is required. Just one of my personal experience of at least in more than 500 patients is that when we use amitriptyline, then Professor Saxena has mentioned that 75 milligram is really required. In our setup, we have seen as low as 5 milligram. You know, we do not get less than 10 milligram tablet. As low as 5 milligram, half the tablet of amitriptyline does lead to sedation or dizziness in, especially in female or especially in novices who are not alcohol user. They so much so that they might discontinue it. So you have to tell them that it may cause dizziness in the initial 3 to 4 days, and if they keep continuing it, this side effect would go off. So preferably, until unless it is too much, they should not stop.
Is there any role of oral steroid in this?
No, I would say that oral steroids do not have a role, and there has been a group of there are 2 schools like orthopedicians are the one school of thoughts which have been very frequently using oral steroids, but I would say all the guidelines, even including the American Association of Orthopedic Guideline, have recommended against users of oral steroids.
Okay, thank you, madam. Now I would like to welcome Professor Saxena, sir.
Thank you. Thank you.
I would like to know from you, sir, when will you go for percutaneous adhesiolisis?
Okay. Well, that's the most challenging one, percutaneous adhesiolisis. I know, especially with Dr. Dureja over here, and the vast experience that he has. But yes, this is where you find when we are talking about, your judgment is purely based on your clinical judgment, and you find that, yes, there is failure of conservative treatment and you have no other option. Everything else has failed, and yes, and of course, we would like to say that you have the MRI picture in front of you. You have the enormous epidural fibrosis, or maybe spinal stenosis also in this case. Let us remember that for every 25% increase in the scarring, it leads to, almost 2 times the incidence of the recurrent radicular pain. And if you find, MRI full of fibrosis, then you find that, yes, the incidence of recurrent radicular pain will be almost 3.2 times. So those are very interesting studies which have been done. So if we have taken a decision for this percutaneous radiculolysis, that means we should have the equipment also available with us. Now, the biggest problem here is, the challenging equipment. I mean, in the sense that if I say that, maybe just 3 or 4 times I have used Rex, that also because I would just like to narrate, because when I had gone abroad, I had just brought it, and that was actually happened to be, an Epimed Tun-L. There is XL also and Tun-L, Tun-L. It is something like that. So epidural catheter which was made available. And, so that particular one is where we have used, and, again, Professor Gabriel Rex, when he brought out this particular entity, way back in 1982 from Texas, the professor of anesthesiology and pain medicine that time. And he started working on this. It was his pioneering work from 89, 90 onward. And so that particular regime, which actually may be a 1-day protocol, maybe a 3-day protocol, and then Manchikanti has brought it further. And if you read the 2016 review article of Manchikanti, 2016, it has level 2 evidence. And if you read the 2019 review article of Manchikanti, which is based on 3 best quality or high quality randomized control trials, he has given it as level 1 evidence. So Manchikanti says level 1 evidence on the basis of 4 high quality RCTs. So that is what I would like to, that how things are evolving with the radiculolysis. And this is where, so when I was talking about that means you were using 16 gauge Epimed RK needle, and that particular one you are using it contralateral side because you got to ultimately deviate it to the affected side. You're choosing a point which is about, say maybe 1.5 centimeter lateral and 1.5 to 2 centimeter inferior to the sacral hiatus, and then you're going and targeting the sacral hiatus, and then you are moving forward, and that particular typical ideal epidural catheter, which was actually a stainless steel, which is again a huge thing, which has got a fluoropolymer coating on top of that, and it has got a spiral tip available with that, which enables you to reach those particular defects when you infuse, your Omnipec dye. So as you are moving this particular Rex tunnel cath, that particular, which is almost 24 centimeter, whatever it is, that particular length, and you're moving it forward right up to S2 or S3 level, and then you're using it in the sense that initially when you're using and you're finding defects, and there you start, the best part of this particular, now of course they have the RenCath catheters, that means they are off the sensitive tissues, which you will, when you are moving through the pathway of least resistance, so they're not producing much problem, but then older models used to create a lot of problem. So that particular one, when you reach that particular target, you're in that particular protocol. If I say the 3-day protocol, you initially inject 1500 units of hyaluronidase, but then please remember that sometimes hyaluronidase is notorious for producing anaphylactic reaction also. So decision is entirely yours, and along with that you push in 10 ml of preservative-free normal saline at that moment. Now this is further followed by around 10 ml of say 0.2% ropivacaine and about 40 mg of triamcinolone, which you may choose. There are people who choose methylprednisolone also. And then patient, ultimately you secure your catheter and shift the patient to recovery area. And then on the 2nd and 3rd day, again, it's a challenging job keeping the patient for 3 days. And every time then in the 2nd day, you repeat your 10 ml of 10% hypertonic saline. Now that availability may vary because most of the time we come across in our setup is 3% hypertonic saline. You may be very lucky if you get 10% hypertonic saline. And that particular 10 ml of 10% hypertonic saline is infused over a period of 20 to 30 minutes. Remember that. But, all said and done, please remember here that it may be very easy for me to say that, yes, I'm using hypertonic saline. There are certain people, certain authorities who don't like it. because if by chance your needle enters the subdural space, or you tend to enter the subarachnoid compartment, you can imagine that means it will have its implications on the central nervous system also. So you got to be very careful. Otherwise, now the catheter technology has improved, so the shearing part is minimized. It is not frequently encountered. So this is what, but then in another, so this is the 3-day protocol, but if you have the difficulty in admitting the patient, then even with 1-day protocol you can use. But then what is more important is what you call it as a, very comprehensive rehab after this particular additional license, which you actually do. And you have got to have all your parameters which you have studied, like Oswestry Disability Index 2.0, VAS for pain, range of motion exercises, those parameters, and work status, and the rescue analgesia. Obviously, you're looking at that. What is more important is follow-up at 3 months, 6 months, and 12 months. That is where the story ends. I know the timing is,
yes,
yeah, that's right.
Actually,
Should I stop over here? Yeah, please tell me. Yeah.
Thank you, sir. So what is preferable according to your experience, single shot or consecutive 3 days?
Oh, 3 days protocol is definitely better. But it's, again, as I said, you need to have that infrastructure, and it's usually challenging. It's usually challenging for you.
Next is which one has better outcome, by Rax catheter or by hypertonic saline?
Oh, well, the one which I was telling you, obviously hypertonic saline is an integral part of that particular protocol. So if you are using Rex, I have also used, in association with neurosurgeon, I have used a 5 French vascular catheter, which was actually, we had pushed it over a 0.035-inch guide wire, which is available, using the help of introducer and dilator. So otherwise, ultimately, the technique is same. So people have seen that the results are almost same, 1-day and 3-day protocol. They have seen, so that kind of reports are there where you find that results are at par. Yeah.
Thank you, sir. Now we are moving to the more advanced procedure. We are going to hear from Dr. Anurag Agarwal. Sir, are you present here, sir?
Yes.
So when will you go for the intrathecal pump in post laminectomy syndrome patients?
Intrathecal pump, you said?
Yes,
intrathecal pump, I think that's the last option. When nothing works, it may work. Before that, there are multiple things that Dr. Saxena sir has already told you. And then if it is required, then you can go for the spinal cord stimulator trial. So intrathecal pump will come in the last, I believe, even after the spinal cord stimulator. And nowadays, another thing which we pain physicians can also offer, depending on the condition on the MRI, as well as the result of all the interventions which we have done for the diagnosis and prognostic purposes, that is percutaneous spine endoscopy. Many of these patients are having remnant or recurrent disc fragments, and which is causing the radicular pain. And sometimes it is amenable to remove that fragment by the endoscope, and that gives the solution of the problem. So intrathecal pump, I personally like to use more in the malignant patients, not in the these benign pathology patients.
So what are the evidences of spinal cord stimulator in failed back surgery syndrome or post laminectomy syndrome?
I personally do not have any extensive experience of spinal cord stimulators. Only few cases I have done. So I think Dr. Dureza is the leader in that. Dureza will tell you the evidence, and he will also tell us about the new advancement in the spinal cord stimulator technologies, which are coming up very fast, like the dorsal root ganglion stimulation, high frequency burst stimulations, and all that.
Dureza sir.
Sir, your mic is muted.
Yes. Yeah. So yes, this is a very challenging, and almost 35 years we have been scratching our head and using all modalities. And of course, the success rate, as you all know, is not very good, in spite of using these advanced modalities. Well, way back, almost 30 years ago, we started using spinal cord stimulators, and the major indication, of course, that time was a failed back surgery syndrome. And of course, then you had the simple Medtronic stimulator. We used to put a 4-lead quadrode, 4 electrode leads, unilateral, bilateral, stimulate, see the test results, and then go in for a pump implantation. Oh, sorry, the stimulator implantation. Initially, the results were good, but over the years, what we found that spinal cord stimulator started going down in a patient, and we had to sometimes, on the request of patient, even explant most of the time. A few of the patients did very well, and I would say only about 30% of patients did very well in terms of VAS score going below 3. Most of the patients had VAS score between 3 to 6. And of course, if the trial failed, we did not go in for this. So this continued, but then there were multiple patients with multiple causes like adhesions, fibrosis, where spinal cord stimulator did not work, and they were on opioids. So we thought that why not use intrathecal morphine pumps for that? And so about 8 to 10 years ago, we put in intrathecal morphine pumps in few patients. They were already taking high doses of morphine for their pain, and that seemed to work. And for neuropathic component, we still add midazolam as one of the drugs. We have preservative-free midazolam and morphine, and I at the moment have about 10 patients across the country where they are managing themselves on these pumps with very severe feedback and reasonably well. Since this technology of spinal cord stimulation got outdated, newer technologies came in, but they were very expensive. First came in the high frequency, and now we have the dorsal root ganglion stimulation, where we place a lead right on the dorsal root ganglion, more specific. We place it right at that place, the dermatome, and we get the stimulation. But again, this is an expensive technology, still not available in our country, but yes, perhaps useful. But having said that you have lots of modalities, but basically the most important thing, again coming back to the basics, is to manage the cognitive behavioral deficit, because that needs a lot of attention. And if you have managed that, you have managed 50% of the problem. So everything goes all along the cognitive behavioral therapy, medications, exercises, teaching the patient how to live with it, lifestyle modification, and all these managements are important. There is no isolation that yes, stimulator gone, pump gone. No, it is not like that. Adhesion is gone. You have to combine all these and let the patient live a better life, improve the quality of life rather than. So you have to give them a realistic expectation. Every patient of failed back or post-laminectomy syndrome has to be given a realistic expectation when you are starting the treatment, that perhaps I may be able to help you by 40%. Take it or leave it, because we can't help you more than that. If the patient agrees, then you start your treatment and tell him that these are all the causative factors, and I'm going to work upon all the causative factors, improving your quality of life so that you can do some purposeful mobility. And this is how it will all go. And you have to follow a step-ladder approach right from day one. If a patient comes, I say, okay, I'll put a pump, I'll put a stimulator. That doesn't work. So you have to start with the basic, find the cause of failed back syndrome, and then move on. So this is how we manage, and we get good success in managing this, but some of the patients do not get good. So you have to be accepting that the results may not be very good in all the patients, but you have to keep trying and keep helping these patients.
Yes, realistic goal setting is very much important.
Absolutely. Absolutely.
Sir, just only 30 seconds, I'll say. For all the participants, for all the learners and beginners, whatever, sir, you have, what Professor Dureja has summed up in last exactly 120 seconds is the most important thing. No one else can. This cannot be explained more beautifully than what he is explained. And this has to be a multidisciplinary approach. It has to be done with all the things together. Self-management is extremely important. Another thing, we can really take our best expert in India is Professor Dureja for spinal cord stimulator and intrathecal drug implants, because I think all over India, he has the maximum experience. In India, we do not have more than 50 spinal cord stimulators, whatever data we could gather till now. So maximum would have been by his experience, and the role of it is definitely fading off, as he mentioned. Thank you, sir.
So now, if anybody has some comments to offer, otherwise I'll put in some questions which the audience has asked. Dr. Saxena, final word.
Yeah, first of all, I would like to thank you, sir. I would like to thank you for your valuable comments. Your expertise really, disseminates knowledge all across the globe. such a vast experience you have. And then I would also like to convey my heartfelt gratitude to Dr. Subrato, Dr. Of course, Dr. Nandi, if I'm correct, how to pronounce, I really don't know. And the whole entire team at ESI Institute of Pain Management, Dr. Babita, of course, being a panelist, Dr. Cham, Dr. Everyone over here, and Dr. Vijay Anand, all the panelists. Thank you so much. Thank you, Dr. Durej.
Again, taking a cue from what you said, if you really want to see what pain medicine is, please visit the ESI Institute of Pain Medicine. Yeah. They have wealth of patients and they're doing fantastic job, not just putting in injection, but doing a complete holistic approach to pain. Debolina, you want to add something?
Sir, how many participants we have? Can we know this? How many number of participants? Number of delegates? Okay.
I have no idea. I'm seeing people from Saudi Arabia and US.
Sir, I want to add one thing.
Number of delegates.
Yeah, please. Debolina.
I want to add one thing that we have so many patients. Definitely, we have less of, but we need to spend some more time with the patient, communicate with the patient, and gain the confidence of the patient, so that our treatment goal is to be fulfilled. That is the only way we, the pain physician, can reach our patient and fulfill our treatment.
Okay, now let us take one or two questions. Dr. Akhtar from Dhaka is asking about, is there any role of chemical adhesiolysis? Dr. Ashok.
Oh, so is it to me?
Chemical adhesiolysis.
Oh, chemical adhesiolysis. Well, all that we were talking about is adhesiolysis with the help of hypertonic saline, adhesiolysis having used hyaluronidase, adhesiolysis having used, and having pushed in 40 milligram of triamcinolone. If at all, I think nothing beyond that, because there have been trials with many other agents and adjuvants. But I think the evidence-based medicine, if we are really following, and then I think we can stick on to these particular agents only. If nothing more I can add, at least in my experience, nothing more. Please.
So there is another question, Dr. Anurag, are you around? How long to continue neuropathic medicine and how to taper them? Nazir Ahmed from Vijaypura. Anybody?
How long to continue neuropathic medicine? Sir, it will depend on the patient response only. And most likely they are going to be increased unless we find something concrete treatment which provides in the permanent relief. The best thing is that these medicines which we use, like the gabapentinoids or the TCAs, amitriptyline, nortriptyline, are considered to be comparatively safe medicine. So they can be given for the longer
period.
From
my personal experiences, there are patients when gabapentin came to India, till today they are on. Yeah. When pregabalin came to India, till today they are on. So number of patients. Don't worry, so they are very safe.
Profile, yeah.
Yes. So there is another question. RAX catheter is costly. So is there anything cheaper available?
I can take this.
Yeah, please.
Sir, I have done few things like the Indian Jugaad for this thing. First is the Vicon catheter, Vicon epidural catheter. It comes with a stylet. It can be used with taking care of the shearing. When you are taking it out, please be very careful about the shearing part, because that is not that strong catheter. It's a simple polymer catheter with a stylet. That can work. Second thing what I have done, I have used is the guide wire. Plain guide wires are available of 0.8 or less than 0.8 millimeters diameter. They can be used to do the mechanical adhesiolysis, followed by the chemical, whatever you are using, hypertonic saline, steroid, or hyaluronidase. Third thing which few of us have done, Dr. Neeraj Jain has done a lot, that balloon, Fogarty balloon, which we have used through the transforaminal route. Actually, I like to do that adhesiolysis more from the transforaminal route rather than from the caudal side, or sometimes from the both sides to make it 360 degree. So these are the three things which I have used. Found them
Sir,
reasonably.
Very well said, Dr. Anurag. These are the jugaads, sir. Only thing what you have to know, that patients, post-laminectomy syndrome patients have already spent so much. Yeah. So even if we are doing adhesiolysis, I think they can spare this much of financial aspect, that we should stick to these are jugaad. He mentioned that. Yes, we should stick to. Yeah, fully agree. So we have done these jugaad.
I will also add one more jugaad which I did, but with a very bad experience. And
Yes,
I
sir.
was working in the urology OT, so there was the ureteric catheter.
Yes,
so I started putting ureteric
sir, I know
catheter.
that. I know that,
Yes,
sir.
you know that.
Actually, Dr. Babita, I would like to add something here. Like,
Yes.
problem with the Rex catheter is not only the money. Is the problem is non-availability.
Yes,
Currently, it is
yes,
not available in India with any vendor.
exactly.
So even if the
Yeah,
patient
you're
is
right.
ready to spend money,
Yeah.
it's not
We need
available.
to, yeah,
You-
we need to work for this. Yes,
You
hopefully.
rightly said, the
Rightly
availability is more important. But
Yes.
let us not forget the multiple passes which are required. That's very
Yes, I
important.
understand, sir.
That's where the shearing force comes into play.
Yes, sir.
The
Yes, sir.
multiple passes, really, we have to be very careful with that. But
Yes,
you
sir.
rightly said, we really, I'm sure, given the
We
kind
need
of
to ensure.
that you can always devise, you can innovate. Why not, Dr. Anurag?
Make in India.
Now, there are
Yeah,
two
make
more
in India.
questions.
That's right.
There are two more questions, which will be the final. Subrata, just give me one minute. There is one Dr. Ajit from Kochi, who he says that I disagree with you on the role of spinal cord stimulator is falling. He is basically pointing towards me. And he says the published literature is very, very encouraging. But see, you can't depend on the published literature. It is your patient, and it is how you get a response from your patient. And it is a very, very expensive modality. If I'm not getting a desirable response in my country, patient is not happy with 50% relief. If he is spending 7 lakhs of rupees, he is happy with zero pain, or at least 90% relief in pain, which I'm not able to give with spinal cord stimulator. Newer modalities are only coming because the previous module of spinal cord stimulator was not working. The high frequency came in, and now the dorsal root ganglion is coming in. So, Dr. Babita, you are wrong. I have done more than 200 spinal cord stimulator right from 1999 till date. So I know how many I have explanted. I know how much results it gives. I am not a proponent of spinal cord stimulator anymore, based on my experience of these patients.
Sir, I'm
And
happy
the
to be
last
wrong.
one-
I'm happy to be wrong. So much known. You have so much of vast experience in
it's
spinal cord.
okay, please. That's fine. But the last one is the best comment. It is from Dr. Malappa from Secunderabad. He is a neurosurgeon. He says it's an excellent webinar, and I, as a neurosurgeon, appreciate all your efforts. Thank you very much, Dr. Malappa. Over to you, Subrata. Over to you, Subrata. Please, your mic. Put your mic on.
Sir, we
Yes,
came
sir.
to know about
Yes, sir.
delegate
Can-
number.
Can you hear me now? Yes, sir.
Yeah,
So I had to switch the device from the laptop to my mobile for some reason. So thank you all and for spending more than 2 hours on a Sunday. And we are grateful to the delegates. We had more than 420 delegates all over the world. We got delegates from Saudi Arab, from Nepal, Bhutan, Bangladesh, and many other countries, and not to forget all other parts of our country. So we are really grateful to the delegates and the viewers, and we remain ever grateful to my teacher, our teacher, the teachers of the Indian Pain Physicians, Professor Dureja sir, for spending so much of time with us. Professor Saxena, I know you are having a very tough time with the COVID duty, but still you
Thank you. Thank you.
so much. Thank you.
Thank you so much.
Dr. Professor Babita Ghai, I know your personal problem, but still you are now at Faridabad, not at Chandigarh, but you are staying with us and interacting so lively. Dr. Cham from Nagpur, you attended, and from Dr. Vijayanand from Coimbatore, Dr. Anurag Agarwal for Lucknow, for very interacting, and we learned a lot from all of you. Dr. Prasad Kesliwal from Nasik, Dr. Devendra from Lucknow, and also Dr. Devolina Ghosh from Kolkata BR Singh Hospital consultant. We are really grateful for your interactive and this experience, sharing your experience and knowledge. Our two moderators, Dr. Gargi Nandi and Dr. Argho Mukherjee, did a very wonderful session. And we must remain grateful to our director of this institute, Dr. Aditi Das, for kindly allowing this session even on Sunday at the institute. Finally, we will remain grateful to Mr. Tushar Chakraborty and Mr. Manoj Mulge of J&J for supporting and helping us to get so many viewers. So supporting this academic piece. So thank you all. And with this, I request our chairperson, sir, to close the session or to say something at the final concluding remarks. Thank you, sir.
Thank you, Subrata, for organizing such an excellent webinar. Since last night, I've been posting in Facebook that this is the most prestigious webinar, and it proved to be the most prestigious webinar. And I'm thankful to you for making me the chairperson and with the elite speakers. And I must tell you one thing, 420 people were listening. In
Yes,
which
sir.
conference has your lecture been attended by more than 40 people? So this is a great effort from you, Dr. Subrata, that 420 people were listening. In my lectures, not more than 40 people are sitting. I travel, go to the airport, take a flight, go to the lecture hall, stay in a hotel, and 40 people sitting, listening. So this is the future now. These webinars are the future. We have so elite people sitting here, experience sharing, and everything we have come to know. Thank you, audience. You have been great. You have been asking questions. We will try to answer most of the questions which we have not been able to answer. And thank you all the learned speakers and the audience for being a part of it. Thank you so much.
Thank you, sir.
Thank you very much.
Very much.
Thank you.
Thank you, sir.
Thank you.
Thank you, sir.
Stay safe.
Thank you. Stay safe.